Good afternoon, everyone. Thank you to all my colleagues attending the Hepato Pernambuco 2021 Liver Talks webinar. It's an honor to begin the scientific event today with a liver talk, drug and liver toxicity, challenging new conceptors. It's also a great pleasure to have my friends, Dr. Devora Joveknix from Porto Alegre, who will co-share with this round table with me, and Professor Nélia Hernandez from Uruguay, Dr. Gautam Mehta and Professor Alberto Quaglia from United Kingdom, together with my Brazilian friends, which I would like to pass now to start the integration to Dr. Devora to introduce the debaters and presenters of clinical cases. We also prepare a small tribute to celebrate this Hepato Pernambuco Silver Jubilee. Welcome to Liver Talks today. Thank you very much, my colleagues here at the meeting.
15 anos do IFP, Instituto do Fígado e Transplantes de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
It's my pleasure to be here in Jubilee of Hepato Pernambuco. I would like to thank to Professor Leila for inviting me to participate. I will call now the Professora Nélia with very pleasure of Uruguay for to talk about phytotherapies and supplements with us. Thank you, Nélia. Coming to us.
Sorry, hi everybody. Good morning. Thank you very much for the invitation. Thank you, Leila, for the invitation. I will talk in Spanish, but my slides are in Portuguese for everybody. Ciertamente que el hígado se encuentra en riesgo. Son muchos los productos, los agentes que producen hepatotoxicidad. Hay descritos más de 1.200 agentes que lo pueden producir, entre hierbas, suplementos dietéticos y xenobióticos. Es un gran desafío el diagnóstico de la hepatotoxicidad y el desafío es aún mayor cuando se trata de hierbas y de suplementos dietéticos. Cuando hablamos de hepatotoxicidad en la práctica clínica, la mayoría se trata de reacciones idiosincráticas, que a diferencia de las intrínsecas o directas, las idiosincráticas se producen en algunos individuos, la incidencia es baja, oscila entre 1 en 100.000 a 1 en 10.000 de los expuestos. Es completamente independiente de la dosis, no como la reacción intrínseca, que es dosis dependiente, acetaminofeno, metotrexate a dosis elevadas. La latencia es variable, puede ir desde días, como la intrínseca, a muchos meses. Es imprevisible, no podemos saber qué individuo va a tener la reacción ni qué tipo de reacción va a tener. Tiene cualquier presentación, desde una alteración del hepatograma a una ictericia, a una fase hepática fulminante, o incluso complicaciones de la cirrosis. A veces el debut es el hallazgo de varices esofágicas, y detrás de eso hay una toxicidad hepática. Puede ser por un daño metabólico o por un daño inmunológico, y por razones de tiempo no vamos a hablar de los xenobióticos, sino que vamos a dedicarlo a lo que es Herbal and Dietary Supplements, el acrónimo HDS, que incluye una gran variedad de productos. La nomenclatura es un poco entreverada todavía, pero dentro de esto tenemos hierbas, tenemos suplementos que pueden tener vitaminas, minerales, aminoácidos, suplementos dietéticos que pueden ser de un ingrediente o multiingredientes, y también están incluidos acá, y es un dato muy importante, a los que se utilizan para aumentar la performance deportiva, a los esteroides anabólicos. Estos productos considerados HDS cada vez están más representados en lo que es hepatotoxicidad. Vemos que con el correr del tiempo, cada vez más su prevalencia aumenta, tanto de los anabólicos como de los productos considerados suplementos dietéticos o hierbas. Esto tiene mucho que ver en la medida que aumenta la venta, como ven ahí la línea roja, aumenta la venta de estos productos, aumentan los reportes de toxicidad hepática vinculados a ellos, y esto tiene detrás un importante mercado económico. Las ventas de estos productos producen hoy por hoy ventas millonarias, y se proyecta que esto sea aún mucho más en los años que siguen. Pero ¿por qué es que empieza a pasar esto? Evidentemente se vende más porque también se demanda más, también se busca más. Entonces, ¿qué es lo que está pasando? Por un lado hay razones culturales. Hay muchos países donde es tradición la medicina natural, la medicina de hierbas. El continente asiático, el continente africano y el continente latinoamericano tienen una cultura de hierbas. Y a su vez aparece en aquellos países que no la tenían una decepción de la medicina tradicional, que no cura todo, no resuelve todo. Por otro lado, las hierbas y los productos o los suplementos dietéticos tienen como una buena reputación. Si es natural, es seguro. Es un error grande, como vamos a ver, esto no es así. El estudio de Islandia es el más relevante al respecto, nos dice que las hierbas pueden ser entre 1 a 3 cada 100.000 personas que la consumen por año, que da toxicidad hepática. Y como también vamos a ver, tiene una alta tasa de hepatitis grave. Hay mucha automedicación, y eso está basado también mucho en el autodiagnóstico. Esto tiene una repercusión importante, que es muy difícil que el paciente reconozca el consumo, que lo vea como responsable de lo que le pasa y que a su vez lo cuente y lo diga, lo que hace más difícil la tarea nuestra. Los controles regulatorios de estos productos son muy pocos. En general se consideran dentro de los controles que se requiere para los alimentos, no para los fármacos. Entonces no hay estudios pre-marketing, no hay estudios post-marketing, no hay estudios de seguridad y de eficacia. Es más, ni siquiera se exige que la etiqueta tenga todos los componentes. Entonces muchas veces en los multiingredientes no sabemos qué es lo que viene dentro. Son muy fáciles de comprar, se compran por internet, son más accesibles económicamente, y a su vez las páginas donde se compran no advierten de ningún problema, no advierten de ningún riesgo y está muy bien planteado y pensado cómo venderlo. Solo aparecen los beneficios. Hay un trabajo que muestra que hoy por hoy más del 50% de la población en Estados Unidos consume alguno de estos productos para el bienestar. Es decir, que esto es muy frecuente y probablemente sea cada vez más. La mayoría de los datos que traje provienen del registro latinoamericano de toxicidad, que es el registro que fue creado en el 2011 a iniciativa y respaldo y apoyo del grupo español, que tiene la sede en Málaga, que creó una red de patólogos que va identificando y caracterizando de manera prospectiva los casos de Dili en el continente latinoamericano. Ahí están los países que la integran y que ya han reportado casos. Tenemos 10 años de trabajo hoy y tenemos más de 400 casos registrados. Lo coordina el doctor Fernando Bestone de Argentina, colaboro en esta coordinación y estoy a cargo del grupo de interés de patotoxicidad de ALE, así que aprovecho a invitar a todos los que quieran unirse, que son muy bienvenidos. Tenemos hoy 404 casos y 135 agentes que están identificados. En el total de los grupos, los antiinfecciosos, igual que en el resto de los registros, son el grupo más frecuente de toxicidad, y dentro de los antiinfecciosos les cuento que son los antibióticos, y dentro de los antibióticos el clavulánico, que está en el top 1 de todos los registros, seguido en el caso nuestro de la nitrofurantoína. Segundo y tercer lugar, parejo, músculo esquelético, donde predomina el diclofenac, y las hierbas y los suplementos dietéticos, que representan el 14% del registro al día de hoy. Cuando vamos a ver cómo se distribuyen las hierbas y los suplementos dietéticos, tenemos 35 para ese grupo, que representa el 64%, y 20 que serían esteroides anabólicos, es decir, el 36% restante de este grupo farmacológico. Al igual que sucede en el resto, también en el registro, cuando analizamos en etapas, vemos que viene creciendo, tanto para los suplementos y las hierbas como para los anabólicos. Latinoamérica es un continente muy heterogéneo. Y en cuanto a este tema de las razones culturales en el consumo de hierbas, también lo es. Como ven, los países que más hierbas tienen reportadas: Brasil, Perú, Ecuador, menos en el caso de Chile, de Uruguay. Argentina tiene un intermedio. Y está faltando un país que forma parte del registro y que no nos ha reportado hierbas aún, que es México, que también tiene una cultura muy importante en hierbas. Cuando miramos este grupo específicamente, de los 35 reportados en hierbas y suplementos, la Camellia sinensis, 8 casos, que se usa como antioxidante y como adelgazante. Lo mismo sucede con la garcinia, con el Herbalife, que son los productos más reportados. La Camellia sinensis es el té verde, que cuando se usa a dosis elevadas, dejando estos efectos, aparece toxicidad. Me parece importante destacar no solamente el número de cuáles, sino que, por ejemplo, tanto la Camellia sinensis como la garcinia, como el Herbalife, y como uno de los productos que tenemos en la miscelánea, porque hay un solo caso, que es el Senecio brasilensis, que está reportado desde El Salvador, todos tienen casos fatales. Es decir, que tenemos 4 casos fatales en 35, eso es bastante alto. Cuando miramos a los anabólicos, la mayoría es el estanozolol. 16 de los 20 no tiene casos fatales, sí lo tiene, al menos en nuestro registro, un caso de alodro. Hay un trabajo reciente que está vinculado a hierbas y a suplementos dietéticos, que lo publica el grupo de Brasil, junto con el grupo de Málaga. Ellos revisan la literatura médica al respecto entre 1976 y 2020, hacen un trabajo de selección muy, pero muy importante, de alrededor de 14.000 papers, y terminan seleccionando, luego de ser sumamente estrictos, 17 estudios, con lo cual hay 23 casos. Los datos que publica el grupo de Brasil están en esta columna, los estoy comparando un poco a los datos de Latinoamérica hoy. y a lo que hay publicado por el grupo español unos años antes. La edad, el sexo femenino, la edad es más bien joven, 44, 46, 48. Hay un amplio predominio del sexo femenino. La reexposición, el re-challenge, es bastante frecuente en este grupo. La forma hepatocelular es más frecuente cuando miramos los registros, algo menos en lo de las publicaciones. Lo mismo sucede con la ictericia. Probablemente acá hay que hacer una salvedad. No es lo mismo revisar lo publicado que hacer un registro prospectivo. Cuando uno revisa lo publicado, tenemos tendencia a publicar lo raro, tenemos tendencia a publicar lo grave, con lo cual algunos datos se pueden cesar. Hay un porcentaje de muerte elevado y de trasplante también elevado en estos pacientes. Y los productos más frecuentes, el Herbalife se repiten todos, la Camellia sinensis, el té verde, también se repite. La centella asiática, que es uno de los más publicados, al menos en el Latin Dili tiene un solo caso. Y la Garcinia camboya creemos que en nuestro continente es una hierba a tener presente. Cuando comparamos los perfiles de drogas con los perfiles de hierbas y con los perfiles de anabólicos, nos encontramos con alguna diferencia en cuanto a la edad, en cuanto al sexo, en cuanto al re-challenge y en cuanto a la severidad. Y se puede generar un perfil, un fenotipo bastante característico de la toxicidad de las hierbas. Y ese perfil son más mujeres, son jóvenes, estamos hablando de 45 años. El perfil de presentación es mucho más frecuente hepatocelular. Se reexpone más que a los fármacos. Esto hay una reexposición inadvertida, porque no se pensó en la hierba, porque no se cree que la hierba tenga ese perfil o ese potencial tóxico. Y una de las cosas más importantes es que hay más cantidad de casos severos y de casos fatales. Cuando miramos los anabólicos, nos encontramos que son más hombres que mujeres, que son más jóvenes aún, 30 versus 50. No hubo re-challenge en este grupo. El estanosol es sin duda el más frecuente. La forma hepatocelular también predomina sobre la colestática mixta y todos tienen ictericia. En la experiencia personal, además de ictericia, tienen mucho prurito. Un prurito muy intenso y que dura bastante tiempo. En definitiva, y como conclusiones de todo esto, el diagnóstico de hepatotoxicidad hay que tenerlo presente para poder diagnosticarlo. Pero la suspicacia que hay que tener cuando se trata de hierbas o de suplementos es aún mucho mayor. Tenemos que tenerlo mucho más incorporado en nuestro algoritmo de estudio y tenemos que ser más empáticos con el paciente para que el paciente lo cuente y nos pueda orientar para el diagnóstico. Los registros tienen una enorme importancia en toxicidad hepática, en hierbas también y más. Nos permiten definir perfiles. Para hacer el diagnóstico de toxicidad por hierbas aplicamos el mismo algoritmo que para los fármacos. Las hierbas, suplementos, cada vez más prevalentes en el registro. Esto es consecuencia de que es cada vez más prevalente su uso. La Camellia sinensis y el estanosol, al menos en el registro latinoamericano, son quienes ranquean primero en este grupo. Y Latinoamérica tiene una tradición enorme en el uso de hierbas. Nos falta incorporar más y probablemente lo que estamos viendo y lo que les mostré es solamente la punta del iceberg de este programa. Muchas gracias por la invitación y por estar hoy acá con ustedes.
Muchísimas gracias, profesora Nélia, pela sua excelente apresentação. E agora nosotros vamos a chamar o professor Aécio Meirelles, grande parceiro na hepatotoxicidade no Brasil, de Minas Gerais, o professor associado do Departamento de Clínica Médica da Faculdade de Medicina da Universidade Federal de Juiz de Fora, membro efetivo da Associação Europeia para Estudos do Fígado do ISO. Professor Aécio, por gentileza, queira apresentar o seu caso clínico nesse momento.
Boa tarde a todos, obrigado, Divora, obrigado a Leila pelo convite, um prazer estar aqui. É um paciente que foi internado primeiramente pelo hemato, um paciente de 67 anos, lavrador, que há 30 dias começou com dor abdominal e notou um discreto aumento do volume abdominal e edema de membros inferiores. Ele foi hospitalizado, ele era um paciente diabético e com hipertensão arterial, já tomando glibenclamida, atenolol e captopril já há vários anos. Um índice de massa normal, mas apresentava uma icterícia discreta, não tinha sinais de doenças crônicas, mas tinha uma hepatomegalia e uma esplenomegalia. Devido a isso, foi internado na hemato com a suspeita de linfoma. O próximo, por favor. A hemato, se puder passar o próximo. Feitos os exames, foi feita inclusive uma biópsia de medula, que foi normal, e foi pedido um parecer da gastro, mas para nível ambulatorial nós acompanhamos esse paciente durante uns 30 dias, como os exames não melhorassem, reinternamos, e ele apresentava de importante no exame hematológico uma plaquetopenia, tinha uma certa insuficiência renal, que depois foi dita como sendo pré-renal no início, bilirrubina discretamente elevada às custas da fração conjugada, uma transaminase pouco elevada, 4 vezes o normal, com a fosfatase alcalina 2 vezes o normal, e faltou aqui uma gama-GT que era de 6 vezes o normal, e LDH normal. Na pesquisa diagnóstica, foi feita em saturação de transferina normal, pesquisa de marcadores virais, era portador já de uma hepatite A antiga, um alfa-1 tripsina e tinha uma IgG também em níveis normais. Próximo, por favor. Dentro do ultrassom feito, e na época nós não fizemos Doppler, a gente tinha muita dificuldade na faculdade, um fígado discretamente aumentado, mas com características normais. Chamava atenção, no slide que eu mandei para o pessoal discutir, tinha um erro, ele não tinha dilatação de vias biliares intrahepáticas, a vesícula não tinha cálculos, chamava atenção, dilatação da veia porta e uma esplenomegalia. Ultrassom, a endoscopia não mostrava sinais de varizes de esôfago. O próximo, por favor. Aqui eu quero chamar muita atenção em termos do pessoal, dos clínicos, porque é muito comum nós clínicos, nós patologistas, às vezes, fazemos o diagnóstico sempre por exclusão. Esse aqui foi o contrário, foi a patologia que deu o diagnóstico, nós fomos correr atrás da etiologia. Por quê? Como nós não tínhamos diagnóstico, foi feito a pedido de uma biópsia hepática, e nessa biópsia hepática houve lesões importantes, nós chamamos a família, fomos conversar no consultório, no outro ambiente, e foi dito, então, que ele fazia uso de Confrei, uma substância sabidamente que pode dar problemas hepáticos, talvez a mais frequente, erva, e que já estava fazendo há mais de 6 meses por motivos de distúrbios abdominais. Próximo, para mostrar. As lâminas eu não vou discutir muito, porque nós vamos ter patologistas para discutir isso, quem sou eu para me entrar nessa área, mas o próximo, por favor. Mas dá para ver uma certa dilatação sinusoidal e uma fibrose perisinusoidal. Encerrando, eu queria chamar a atenção para o próximo, em termos de discussão de drogas, o que a gente pode pedir? Quando é importante a gente biopsiar, porque não é comum a gente biopsiar nesses casos, porque os casos, na maioria das vezes, são maduros. Essas doenças clínicas são semelhantes entre mulheres e entre os homens, parece que já foi mostrado ali anteriormente. Como nós devemos e podemos graduar num contexto clínico do dia a dia, se um paciente, principalmente se tem uma lesão hepatocelular, qual é a gravidade, qual o prognóstico? E quando se deveria usar corticoides, principalmente em doentes com colestase, se funciona e se não funciona. Quero agradecer a todos, desculpem pelos distúrbios.
Então, muito obrigada, professora Estes, pelo caso, bem interessante. Vamos ter várias possibilidades de discuti-lo, e, para isso, nada melhor do que os nossos grandes professores patologistas, os nossos debatedores serão o professor Venâncio e o professor Luiz Freitas, e eu vou apresentá-los. O professor Venâncio é um professor titular do Departamento de Patologia da Faculdade de Medicina da Universidade de São Paulo, e o professor Luiz Freitas, da Bahia, é um professor adjunto da Universidade Federal da Bahia e pesquisador titular da Fundação Oswaldo Cruz. Atua na área diagnóstica de patologia hepática em geral. Sejam bem-vindos e um bom debate. As questões já foram algumas colocadas pelo professor Aécio. Vamos começar, então, por favor.
First of all, I would like to thank very much Leila and the organizers of this meeting for inviting me. And I would like to congratulate them for the organization of so interesting and rich meeting, okay? I think that this first case is really probably related to toxic effects of the Comference. Comference is a well-known hepatotoxic herbal products. Leaves and roots have been used to treat wounds and to decrease pain and inflammation. And in Comference, there are many substances that have anti-inflammatory and wound healing activity. But there are also other substances that are known to be toxic, mainly for hepatic endothelial cells, okay? And because of that, this product has been banned in many countries, but I think that not in Brazil, okay? The toxic effect of this herbal product causes what we call nowadays as obstructive sinusoidal syndrome, that was called before as a veno-occlusive disease. And this kind of alteration is due to the toxic effect of alkaloids in endothelial cells. These alkaloids destroy endothelial cells in the sinusoidal vessels and in the central vein. And it causes obstruction of these vessels and also extravasation of red blood cells. Well, I think that the pictures that were shown related to these cases were taken in a late phase of the process, because what we see there are mostly related with the healing process. We have some degree of perisinusoidal fibrosis and also a small amount of fibrous tissue around the central veins, and very mild hepatic congestion. And I think that's the comments that I would like to do, and say that we have seen many cases of hepatic toxicity related to all alkaloids like these, but related with other herbs that are used all over Brazil.
Nélia, queria aproveitar a tua palestra junto com o caso do professor Aécio e te solicitar alguma das respostas. Quando tu indicaria biópsia, é super importante para nós clínicos, nesses casos, até onde nós vamos e até onde nós vamos com corticoterapia também. Isso é para nós que tratamos, por favor.
Sí, el rol de la biopsia es un poquito controversial en el caso del Dili y de Dili. Yo comparto con el doctor Freitas lo que dijo. Este caso es inusual. Tenemos casos que se presentan con hipertensión portal, con ascitis, pero no es lo más frecuente. Y además de las hierbas, hay otros agentes que también lo dan. En la experiencia nuestra, el oxaliplatino como quimioterápico también se presenta así, con latencias largas, con una evolución que se independiza de recibir la hierba o el fármaco. Y en esas situaciones donde la presentación es inusual, la latencia es larga, quedan dudas, o tenemos dudas a veces con el perfil autoinmune, que no es el caso que presentó el doctor, pero muchas veces no sabemos si es un Dili, un autoinmune, o un Dili con fenotipo autoinmune. Son casos donde la biopsia realmente ayuda y ayuda mucho. En el caso que mostraron creo que es muy importante, porque era un paciente, si lo mirábamos clínicamente como cirrótico, la biopsia mostró exactamente dónde estaba la lesión, y sabemos que la lesión sinusoidal, la lesión endotelial como la que mostró, los fármacos y las hierbas hay que levantarlos en la etiología. Y a veces es después de la biopsia que vamos a reinterrogar al paciente o a reinterrogar a la familia que nos ayude a encontrar el producto que lo puede estar explicando. Esas son las circunstancias donde hacemos biopsia. Los casos que les mostré del Latin Dili, ninguno tiene biopsia.
Gracias.
Devora, can I ask in English for the other speakers? Professor Gautam and Professor Quaglia, the question is, when could you do a liver biopsy to have the diagnosis for drug-induced liver injury? Professor Gautam, in your opinion?
Yeah, thank you. I mean, I think we quite regularly use histology once we're, if we're stuck. Of course, you know, there are experimental biomarkers, but we don't have anything conclusive in these complex cases. Once we've done our first and second stage workups, we have quite ready access to transjugular liver biopsies actually in our center. We do the majority. So I think we probably use that mode quite a lot. Don't you think, Professor Quaglia?
Yes. What do we get out of the histology? I'll cover it in my talk, but essentially what the way the liver reacts to injury is very, very limited. So there is a limited number of patterns, and they are identical regardless of the etiology. So you can have viral injury, which looks the same as a drug-induced. So yes, we do use histology, but it's always very, very important to put it into context from the diagnostic point of view. And then on a liver biopsy may help in gauging the severity of the liver injury, but there is an issue with sampling variation. So we always need to be aware of that. So yes, histology is part of the puzzle, I think. It's a contribution, sometimes it is important, but it needs to be put into clinical context very much. And with drug-induced liver injury, a detailed clinical history, I think, is absolutely critical.
I think that Alberto brings a question that is very important in cases of SOS, is that the lesions are not homogeneous in the liver, and maybe liver needle biopsy will not sample areas where the lesion is present. Also, we have to be very aware about the risk of bleeding of these patients, okay? And there are some clinical criteria that are used. I'm not a clinician, a physician, but I know that there are Seattle criteria and also a Baltimore criteria. And since you have the suspicion that the patient has a SOS syndrome, you can make a clinical diagnosis.
Well, first, congratulations for the meeting and for the 25th Jubilee. It's very nice to be with all of you. The case is quite interesting, and repeating and stressing a little bit more what both pathologists said, our goal is to have the pattern. The pathology, even without clinical data, must recognize the pattern of lesion and then go to clinicians and try to put in the right context. But the pattern we see drives our rationale, our hypothesis. In this very case, you were very economic on presenting such a small sample for pathology, but even so, we can see, at least at the trichromic, some fibrosis in blue. So probably it will be SOS, but I'd rather to have a better sample to comment on. Thank you.
Thank you, Professor Venancio. Professor Alberto, please, you want to ask something?
You want me to?
Yeah, Devora,
No.
Can you ask some questions for him from the case?
No, it's not question, Leila. Not question. Any one question in Q&A. and the
No,
chat.
I'm saying from the case, from o caso, Devora, o caso tem 4 perguntas para...
Yes. The case, I want to know about the treatment with corticotherapy. What is the best moment for to use? And if you use in this case or no, you wait for how many times you wait?
Thank you for asking me this question, but I cannot answer. I'm a pathologist. I think Gautam would be the best to.
Yeah, happily. So it's, I mean, look, so the question about steroids in drug-induced liver injury is a very, very old question in hepatology, and really, depending on which study you pick, you can toss a coin and decide which answer you want. Most of the studies and case series are very small. There's no very large, well-powered study. I think overall, there's no real benefit. In our cohort here at the Royal Free that Professor Quaglia is also involved in, there was, again, no independent benefits of steroids in this group. So I think if you're going to use it, you can be very cautious and have some stopping rules. There's no widely demonstrable beneficial effect of steroids in acute severe drug-induced liver injury.
Okay, thank you. Thank you, Gautam. Please, Leila, I don't have more questions in Q&A, and I want to I ask you if your question has more 2 questions. I ask you.
Não? O que você traduz para mim?
Se tu pudesse dizer, tu tens ainda alguma questão sobre o caso que tu levantaste antes, tu poderia repetir, por favor?
Não, acho que a grande importância dele foi a biópsia ter definido, e quando eu coloquei as questões, foram as questões para definir. Eu acho, já foi falado pela apresentadora Nélia, que a diferença de Dili para Dili, e em termos dos corticoides, eu acho que a grande indicação seria na suspeita de hepatite autoimune, e hoje acho que nós, hepatologistas, vamos precisar de aprender muito sobre os imunomoduladores de checkpoints, quando produzem reações, essas reações têm um efeito de autoimunidade, e que os oncologistas usam muito largamente os corticoides, que funciona bem. Eu acho que aprendi muito também com esse caso, com todas essas discussões. Muito obrigado.
May I ask one question? May I ask one question?
Sure.
In cases like this, there is indication of anticoagulation for these patients. Or if someone has experience in cases like this, specifically SOS, if the use of anticoagulation or antithrombotic medicine is indicated.
Can you answer, Gautam?
Yeah, so
anticoagulation in this case.
Yeah, so I think for SOS or VOD syndromes, a lot of them that we see are in the context of bone marrow transplantation or chemotherapy. And so presentation with drug-induced liver injuries is a relatively rare mode of presentation of this syndrome. In those patients, they're usually thrombocytopenic. They're normally contraindications to systemic anticoagulation. In the rare group like this, I think you do it case by case. Certainly, there's no reason not to give a prophylactic dose. We wouldn't typically give a therapeutic dose, though. Of course, the pathology is shedding of endothelial cells and intravascular blockage rather than primary thrombosis. So I think that would be the approach. But in our center, we see quite a lot of SOS, VOD, but most of it is in the context of hematological malignancy and therapy rather than Dili. So I think that's an important message to get across.
Deborah, let me ask you some questions to Gautam and Quaglia. Can you share with us your experience with the herbals in the UK? Because in South America, as you could heard from Nélia, it's very common in South America use herbals. I'd like that you share with us your experience in United Kingdom, please.
Go first, Gautam. I think on the histology, it's probably best to get first the clinical experience because the histology is a smaller cohort.
Yeah, so I think it's not a very common mode of presentation in the UK actually. we see probably 3 to 4 cases a year. Very few are progressed to severe liver injury or transplantation requiring acute liver failure. Most cases of Dili that are in the UK are through prescription medication. So it's probably far less common here than it seems to be in Brazil.
I agree with that. I mean, we are aware, of course, of it histologically. It's traditionally mentioned in the textbooks. We have seen it through circulations of cases, particularly with the herbs. Venancio, I'm sure, remembers some of the cases that we discussed in the past. But and there is clearly a lot of use of herbal remedies in this country. But if I have to think of a case recently where I saw this sort of injury or something that could be related directly with an herbal remedy or something of that sort, I really cannot think of one. And we do see a lot of Dili, but of a different type and usually related to therapeutics. In that respect, I agree with Gautam. It's interesting. It's certainly when we think of Dili, we need to think of geographical variation. What we may see in one country is very different from what we may be seeing in others. Absolutely.
Okay, thank you very much. I think it's time to move on to the next lecture because we have to be very settled in the time for the webinar. It's my pleasure to introduce Professor Gautam Mehta. He's an honorary consulting associate professor at University College of London. He's going to present a mini conference with COVID-19 and liver, the new pathology. Thank you very much, Gautam, to stay with us in the webinar Liver Talks in Pernambuco 2021, please.
Yeah, well, thank you very much for the invitation. I'm very, very happy to be here with you. Can you see my slides okay? Good, okay, so I'm going to talk about COVID-19 and the liver. And thank you again for the invite. What I thought I would talk about is COVID-19 in the context of chronic liver disease and liver transplantation, which of course we're all learning a lot about. We've learned a lot in the last year. The mechanisms of liver damage in COVID-19 in particular we can touch on. And then of course we're now in the vaccine era. Although there's a lot of data from clinical trials, we don't know a lot about vaccination in patients with liver disease or liver transplantation. So we can talk a bit about that and talk about which studies are in progress to try and answer those questions for our patients. So if we go back about a year and a bit, the very first cases were, in Europe at least, came from initially from China, but of course the first in Europe were in Italy, in Lombardy. And this is really where we saw the first severe liver disease cases and the first data was generated. And it was clear straight away there was something a little bit different about cirrhotic patients with COVID-19 against the usual presentation. It was clear that of these patients, about a third had liver-related mortality on the background of COVID-19, unlike patients who had the absence of cirrhosis. And actually, liver disease was very important in the prognosis. So you could very clearly see there was a difference in patients with severe liver disease with a high MELD score as opposed to those with a low MELD score. And actually, the overall mortality was very much linked to the development of organ failure. The CLIF-OF is the European Foundation for Chronic Liver Failure, EF-CLIF scoring system. So the mode of death was often through the progression to multi-organ failure. So there was something a little bit different about these cirrhotic patients compared to non-cirrhotics who developed COVID-19. And of course, the other thing to say is that these patients had quite poor outcomes. Very, very quickly, the hepatology community got together and started these registries, which I think is a huge credit. The COVID Hep registry is a European registry. Secure Cirrhosis is a North American registry. And what you see is that in patients who have chronic liver disease and then cirrhosis, Child-Pugh A, B, and C, the severity of disease based on intensive care requirements, renal replacement therapy, and also death is very markedly increased in patients who've got severe liver disease. And what we know in patients without cirrhosis is that it's the elderly that are very vulnerable, and you have this inverse pyramid with low mortality in the younger patients. But if you look in the cirrhotics, again, this is completely lost. So there's no protection if you're younger. There's vulnerability to poor outcomes regardless of age. So cirrhosis is a very strong independent risk factor for poor outcome in COVID. And as I mentioned, what was unusual about this is that this seems to precipitate decompensation in patients with severe underlying liver disease, again, stratified by the severity of the underlying liver disease. So the proportion that present with decompensation is actually quite high in Child-Pugh-C. And again, the severity of liver disease is very closely related to mortality, as is the degree of multi-organ failure. So if you have chronic liver disease without cirrhosis and no organ failure, then actually your mortality rate is relatively low, but this increases stepwise. So severe underlying liver disease and requiring significant organ support predicts a very poor outcome. And again, this is very, very similar data, propensity scored matched data in the UK to patients without chronic liver disease, showing a very high increment in risk of death with severe underlying chronic liver disease. So I think the message here is that cirrhosis certainly leads to worse outcomes, and the relative risk of death is probably around 5-fold increased in patients who have cirrhosis. So what about those who have liver transplantation? This is also UK data. It's less clear, and there may be some protective factors here, but in this cohort, which are based in the UK, there was an increased incidence of ICU admission and increased requirement for organ support. This may be slightly confounded because maybe these patients had a lower threshold for ICU, were slightly had slightly better care, if you like, in liver transplant centres. But it's echoed in other cohorts too. This is a large European cohort which showed that there was potentially increased risk of death in patients who had underlying chronic kidney disease as well as liver transplantation, and those who are older. So again, there's some propensity to worse outcomes. In this paper, it was suggested that tacrolimus may be slightly protective. That's not been borne out in another study, but interesting data nonetheless. So what's happening in these liver patients? I know I'm surrounded by many eminent pathologists, so I thought I'll try and show at least one slide, even though it's not great quality. But this is a paper that one of the first ones from China that came out characterizing liver injury in individuals with COVID-19. These were patients who did not have described underlying chronic liver disease, but it was very clear that ALT, AST, gamma GT are independent predictors of outcome. And what was nice about this paper was that they showed some liver histology. What they suggested was that there's increased apoptosis, which is what they showed on the H&E stain. They suggested that there's direct infection of hepatocytes with coronavirus. This is on the transmission electron micrograph with 60 to 120 nanometer particles within hepatocytes. And a tunnel stain is a stain of cell death, suggesting there's very markedly increased hepatocyte cell death. So we wrote a letter to this paper. Actually, we thought, well, this can't be right. Look, there's no ACE2 expression in hepatocytes. So how could this be? Is there something else you're seeing? Are these extracellular vesicles that you're seeing instead of virus particles? But actually, when you look into the literature and when you look more deeply, we're probably wrong, because ACE2 is expressed in cholangiocytes. It's not expressed in hepatocytes at baseline, but it's inducible in chronic liver disease. So actually, in individuals who've got underlying chronic liver disease, it's quite likely that there is hepatocyte infection and hepatocyte death. So what we may be seeing is increased tunnel staining and hepatocyte injury in individuals who've got an element of underlying chronic liver disease, and that might partially explain the worse outcomes. We've done some work on cell death pathways in COVID-19 infection. This is with a group in the US. And what's very clear is that some of the pathways that cause cell death, their inflammasome pathways, are very highly upregulated and involved in COVID-19 infection. This is in monocytes in the healthy individual, but we know that these pathways are also very upregulated in hepatocytes in chronic liver disease. So I think it's very likely that coronavirus infection induces inflammasome-mediated hepatocyte cell death in patients who've got underlying chronic liver disease. And this may be the mode of progression to decompensation and acute on chronic liver failure, unlike patients who don't have underlying chronic liver disease. Okay, so I'll just change gears slightly and talk about transplantation now and vaccination now in patients who've got cirrhosis and transplantation. So of course, we all know about the vaccine programs in varying countries and the major vaccines that are available. And this is a huge triumph in such a short period of time, but the studies are very poorly representative of patients who've got underlying chronic liver disease. The Pfizer studies had a huge number of subjects, but of this 43,000, only 3 had underlying chronic liver disease. In the AstraZeneca, they were completely excluded from the trials. And in the Moderna study, there are a small number, but there's no sub-analysis on these individuals. And of course, they're very small numbers in any case. So we know very little from the published trials. And is there reason to consider that patients with cirrhosis or liver transplantation may have altered vaccine responsiveness? Well, of course, chronic liver disease associated immune dysfunction is very well described now, and we know a lot about innate immune dysfunction, but actually there's a lot of adaptive immune dysfunction as well in chronic liver disease. And we know from other vaccines, this is an example from pneumococcal vaccine, that responses, serological responses are around 20% lower in cirrhotics compared to controls. And actually the durability of response is also much shorter. You see a great fall away at 6 months with this pneumococcal vaccine. And you see very similar things with hepatitis B vaccine as well. So it's very likely that there's going to be a reduction in vaccine efficacy. But of course, we need to gather data. And the other aspect that I think is worth thinking about, although it's important to say there's no direct evidence to support this at the moment, but there's been some suggestion in the literature that if there is suboptimal antibody response to vaccination, so your antibodies are poor quality or they are low in number, in titer, then actually you could have opsonized viral particles that are taken up non-specifically by Fc gamma receptors on innate immune cells in this case, which paradoxically could cause pro-inflammatory responses. So if you have suboptimal clearance of viral particles, then the opsonized complex could actually lead to pro-inflammatory responses. And we have some in vitro data to support that, but of course there's nothing yet in the literature to suggest this is happening in a wide scale. But in patients who have cirrhosis or transplantation, it's a potential possibility. But I guess it's important to start off the sort of real world look at data and say that we're in a pretty good place actually with vaccines. This is UK data, so I don't think you've seen this. This is reported every week, and this is from about 2 weeks ago. And I think this is very comforting. It shows that there's very good responses. The triangle here is anti-spike IgG. The circles are anti-nucleocapsid. These are the age ranges. And what you see is the anti-nucleocapsid, which is the baseline level of infection, is still relatively low, but as the various age groups have been vaccinated, you see a very marked increase in anti-spike antibodies, both in this is the 70 to 85-year-old range, 60 to 70, and then 50 to 60. So they're all getting it to 95%. Very, very encouraging data. And the other interesting thing you can pull from the national data is how long this single-dose vaccination protection may last. So we in the UK have been separating vaccine doses by 12 weeks for Pfizer and AstraZeneca. I'm not sure what you're doing in Brazil, but this is longer than the recommended 3 to 4 week regimens. So this here is Pfizer on the left. This is AstraZeneca on the right. This is the odds ratio of symptomatic infection after a single dose. And this is nationwide data, very large numbers. And what you see is that there's marked protection from symptomatic coronavirus infection with this very big decrease in odds ratio. But interestingly, what you see, especially with Pfizer, is that after around 12 weeks, there's a loss of protection probably. And so, and you don't quite see that with AstraZeneca. So certainly there's a limit to the durability of response from one dose at the very least. So this is obviously a very useful resource to look at real world outcomes, although it's not in a clinical trial setting. It's worth emphasizing. But we do have some data in liver transplantation as well now. This was a letter published in JAMA around 2 months ago now, amongst a group of organ transplant recipients who had received 1 dose of RNA vaccine at that point, Moderna or Pfizer. And again, it's quite striking. Again, this is only 1 dose, but you see that around 2/3 of this group who had liver transplants had no detectable serological response after a single dose of mRNA vaccine. Okay, that's only 1 dose. So the same group followed the same cohorts, now up to 2 doses. And what you see here, the lines are the increment in serological response. This is receptor binding domain. This is spike. And these are individuals who had a positive at after dose 1 and who incremented to dose 2. The dots are those who did not have a positive at dose 1 but went on to develop something. And these are undetectable. But actually, again, around 20% have no detectable serological response at all after 2 doses of an mRNA vaccine. Now, the problem with that last cohort is that there's no control group. So even in those who have a positive response, we have no idea what the effective threshold of protection is. But this is data from Israel, where they're very far ahead in their transplant program. And again, you've got 80 transplant recipients and some healthy controls, importantly. So and the data are very similar. And even in patients who have a detectable serological response, the levels are very much lower than healthy controls too. So I think it's important to say that these patients in a proportion will not have any protection at all, at least serological protection. And we're yet to know what the threshold of protection is with long-term data. So I think we're a long way from knowing exactly how best to treat these patients and whether they need additional protective measures. We're doing a large study in Europe. So we're involved with a consortium, which includes the European Foundation for Chronic Liver Failure. ELITA is the European Liver and Intestine Transplant Association, and the Foundation for Liver Research, who I collaborate with, to fund a very large study of around 3,500 individuals across Europe who either have cirrhosis or post-liver transplant. And we'll sample them in the window immediately after their final vaccine dose, and then about 8 months or so later, and then we'll collect data up to a year to look for long-term outcomes and protection. So this is in place now, and I hope we'll be able to report some data in around 3 to 4 months or so. Okay, so I'll close there. I think it's important to say that COVID-19 has got very poor outcomes, particularly in cirrhosis. The mode of progression is more related to decompensation in a number of patients rather than the typical pulmonary presentation. It's associated with hepatocyte injury and hepatocyte cell death. And although we have some data on vaccine efficacy, we still need to fill in those gaps, and that's where studies like COBALT may be important. I'll stop there. Thank you.
Thank you very much, Gautam, for excellent exposure lectures, especially in the vaccination, COVID-19 vaccination trials. COBALT in the liver transplantation is very important for us. In Brazil, using now 3 vaccines, is Coronavac, AstraZeneca, and Pfizer. There is a 3 vaccine in Brazil available at the moment. I pass to the case. Devora, can you present?
Okay.
The debaters could be talk together.
Agora eu chamo o Matheus Mikelchuk para apresentar o caso, que é o nosso mestre em gastroenterologia e aluno do doutorado do pós da gastroenterologia, e um grande parceiro, colega nosso, médico do Serviço de Gastroenterologia do Hospital de Clínicas. Por favor, Matheus, queira apresentar teu caso.
Okay.
Yes.
Well, thank you for the kind words of Vora, and I'd like to thank Professor Leila Pereira for the kind invitation to participate in this traditional meeting of Brazilian hepatology. And I present the case of a 72-year-old female with history of hypertension, diabetes, obesity, and dyslipidemia. She was submitted to bariatric surgery in 2016, and nowadays he's getting glibenclamide, metformin, simvastatin, and omeprazole. She denied previous liver disease, alcohol use, tobacco, and other drugs. In December 2020, she had COVID-19 with 25% of pulmonary involvement at CT scan. At that moment, it was prescribed a combo treatment that includes azithromycin, ivermectin, prednisone, zinc, anti-inflammatory drug, and vitamin D. There's no need for hospital admission at that moment and no further complaints. But she progresses with respiratory symptoms, and January 21, she started prednisone because of organizing pneumonia. And she uses this corticosteroid from January to February. In February 21, she has a GI appointment due to dyspeptic symptoms. At that moment, there was an elevation of liver enzymes with AST on 345 and ALT 770. Normal abdominal ultrasound at that moment, and no other investigation was carried out at the time. In March 21, she has a new GI appointment with malaise, asthenia, and jaundice. At physical examination, she was an obese patient, BMI 36. She was jaundiced. She has discrete palmar erythema and some vascular spiders at the chest. No signs of hepatic encephalopathy. The cardiopulmonary examination was normal, and there was no visceral megalies, no abdominal pain, and there was no ascites at the physical examination. She was submitted to a laboratory analysis that showed increase in AST and LT, 1,400 each, a bilirubin level, total bilirubin 14, and direct bilirubin of 11.7, alkaline phosphatase and gamma GT elevated, prothrombin time prolongated to 18.6 seconds for a control of 13 seconds. Platelets were normal, anti-nuclear antibody elevated, and immunoglobulin G also elevated. At that moment, she was submitted to an MRI that shows a liver with normal size, diffusely heterogeneous signal intensity, compatible with acute liver disease. Normal spleen, absence of ascites or bile dilation. At this time, she made a cholangioresonance also that was normal. She was admitted at a general hospital here in Porto Alegre and stayed there for additional 5 days. So after these 5 days, she was transferred to our hospital. And at liver unit admission, she was in poor general condition, jaundiced, and with hepatic encephalopathy, confusion, and with flapping in West Haven, grade 2. And the laboratories of admission, she stays with the AST and LT very elevated. The bilirubin doubled the value of 10 days or 12 days before, 28 in total bilirubin with 20 bilirubin directed. The prothrombin time was more prolongated. The platelets are normal, and factor V 25% at the admission, hospital admission. Other causes of viral hepatitis were excluded. Another autoantibodies were all negative, and she progresses with liver dysfunction. She received antibiotics, received an acetylcysteine and prednisolone at that moment. And she meets the King's College criteria on April 1st, I think, and progressing to acute liver failure. And she was listed to liver transplantation after a multidisciplinary discussion, and submitted to liver transplant on April 3. So here's a quick summary of the case. The patient has COVID-19 diagnosis in December, liver function tests elevated in February, liver failure in March, and was submitted to a liver transplantation in April. And there are the explant analysis. Just remember, I'm not a pathologist, I'm a hepatologist, so these images are to illustrate the case. and to generate some discussion, but not a deep discussion. Not doing a deep discussion about this. We can see a cirrhotic liver with kind of puzzles, squares and kind of puzzles pattern at macroscopy. And in the microscopy, there are cirrhosis with biliary pattern with periductal fibrosis in the onion skin, the presence of also coalescent necrosis and lymphoplasmacytic infiltrate and interface infiltrate also. There are no elements for NAFLD. And with the final diagnosis, this is a coloration showing plasma cells. It was acute and chronic liver failure, with the acute component being due to autoimmune hepatitis, and the chronic component due to biliary cirrhosis. The patient is all right. She's alive. She's hospitalized at this moment, treating a CMV infection, but she's okay. And I have some questions for discussion. I bring some questions. This kind of thing, this post-COVID autoimmune hepatitis, is due to only the COVID-19. There are some component of Dili in this kind of situation. How we can differentiate these two situations, Dili and COVID-19 autoimmune hepatitis, and what are the mechanisms involved in this case? Okay, Professor Leila, thank you. This is my questions about the case.
Thank you very much, Mateus. Devora, can you invite the two colleagues to discuss them?
Sorry, Leila, please. Now I have Alberto Quaglia.
Não, a gente vai primeiro discutir o caso, depois é Alberto.
Ah, ok. Só, desculpe, essa parte eu não tenho quem vai discutir os casos.
Venâncio and Freitas, can you...
Okay, please.
Address the case.
Again. Okay, please, I'm sorry, excuse me. Please, Freitas, Venâncio, you beginning now, please.
So this is a very different case from what we have seen. In COVID now, unfortunately, although in the lung phase or acute phase, liver lesions seem to be minor. After COVID, people are mentioning post-COVID syndrome. We have seen at least 10 cases in our practice in the last month, and very different, or quite different. They are spanning from cholestatic hepatitis, mostly to true cholangitis, very fast moving to fibrosing cholangitis. Some of the cases very similar to PSC or secondary cholangitis, and some of them are requiring even transplantation. This case is a little bit or quite different, Mateus. The first question would be, when she did the bariatric surgery 4 years ago, were there any report about the condition of the liver?
No, Professor Venâncio, there aren't any report about the condition of liver at that time. And the further, we don't have don't have examinations previous to this kind of, and there's no relate of cirrhosis at that moment from the surgery. She made, I don't remember the procedure. I think it's a gastric band that she puts in 25 years ago.
So no report, no MRI, no CT, nothing mentioning. Let us assume that steatohepatitis was not important, no micronodular cirrhosis from the origin. Let's assume that there is no, because it would be quite different if we had this information. So you showed cirrhotic liver with cholangitis. Probably you were trying to depict sclerosing cholangitis pattern, and also you showed a kind of lobular and periportal, periseptal activity rich in plasma cells. So the point would be that would be autoimmune hepatitis associated with cholangitis. So if this is the case, it would possibly be related to some drugs, and the drugs you mentioned, it was glibenclamida, a sulfonylurea that is not reported to cause more than mild hepatitis. You mentioned simvastatin, not very common, but up to 5% I read might lead to cholestatic hepatitis. But the point is that the COVID that the patient had was mild, as you told us. That is also very different from what has been reported, that people under mechanical ventilation, under multi-drugs, and even ECMO might be the ones who would have more severe. So this is my summary. I could not assign a specific mechanism for the lesions, but my position would be that she might have previous NASH, then COVID was rather mild, the drugs were not very directly related, and then you have a pattern that would be plasma cell rich, lobular and periportal, periseptal hepatitis. That's my summary. Thank you.
Devora, there is one question for the Q&A from Professor Ilka Boim from Campinas, Brazil. She asked you what's the difference, if you could differentiate this lesion from COVID-19 or ivermectin drug-induced. Gautam Freitas.
I had a case of overdose of ivermectin, and what we saw was cholestasis. Was completely different from this, okay? And I think that this is a very difficult and intriguing case. We have a patient that seems to have a chronic liver disease, unsuspected, but undoubtedly, this patient had a chronic liver disease. She had cirrhosis, and then supervened acute on chronic liver disease. And there are morphological findings that it's akin to autoimmune hepatitis with very intensive activity and with extensive hepatic necrosis, okay? And the question is, there is any relationship between COVID-19 and the development of autoimmune hepatitis? In the literature, I couldn't find any. And yesterday, I found one report of someone that was vaccinated against COVID-19 and developed autoimmune hepatitis. And the title of this paper is very interesting because it's autoimmune hepatitis developing after coronavirus disease vaccine, causality or causality, okay? And this is a question that we cannot answer by now, but it's very interesting because there are reports of autoimmune disease, not liver autoimmune disease after COVID-19. And I found a report that lists at least 26 heptapeptides shared by the spike glycoprotein of the SARS-CoV-2 and human peptides, including the hepatocyte receptor for hepatitis virus A. So it's very difficult to answer this question, but I think that we have to be aware of this possibility.
I completely agree. I've seen one case of a flare of autoimmune hepatitis around 2 weeks after mRNA vaccine. I've also seen one solid organ liver transplant recipient who developed acute cellular rejection after a single dose of mRNA vaccine. But actually, that's all. I think, you know, these are obviously anecdotal reports. Our cohort is quite big, and everyone's vaccinated, and I'm not aware of anyone else. And so, you know, I think it's very difficult without knowing in a systematic way the background incidence in a ideally a observational study. But it's possible. I think that certainly the theoretical basis of flaring an underlying chronic autoimmune disease with superimposed vaccine or viral infection is obviously plausible. And I think that the pathobiology here is very likely a flare of underlying autoimmune liver disease causing the acute on chronic liver failure, from what you suggest. It's just whether coronavirus had any role in precipitating that. The time interval seems a bit long. And of course, like you say, she only had mild disease, but again, if that's a precipitant, it doesn't necessarily need to play a role. I would just caution against sending out a message that there's any causal link here, you know, and I think that we need to see the data. Of course, it's far better that these autoimmune patients who are on immunosuppression get vaccinated than don't. So that's the only caution I would have, but it's possible.
Please, Leila, I want to ask it something.
Please.
In SARS-CoV-2, the critical patients present the secondary sclerosing cholangitis. And now you have a new cholangitis pathology. There are a new cholangiopathy post-COVID, or is the same? I don't know the difference now. I have many cases that have a new cholangiopathy post-COVID, and what they think about it.
It seems it's very important.
Nancio?
It seems that will be very important to divide the clinical epidemiological scenario, because this case is considered a mild COVID. So many of the causes we ascribe the lesions were not present. So if we can divide the so many cases all the world have in clinically well-defined landscapes, we will be able to minimize the multi-causative approach that is making quite a confusion in the papers up to now. So this case is mild COVID and not so many interventions. So this kind of case, if has not original disease, this case should be considered especially in a group probably related to COVID. When you have cases with mechanical ventilation, ECMO, and so many drugs, then you should subdivide. Otherwise, we will be putting causes and making harm more than helping the patients and understanding the disease. It seems to me that Tadeusz Sersky, the pathologist who saw this case, would be in the audience. Could we hear him? Could we listen his comments?
I think I have to open the room because I closed because a lot of participants I'm not sure if Tadeu is in the room. Mateus, you know if Tadeu? I could see on the list, but take me time, even as you to look in there.
I don't see Tadeu.
Se ele tiver, eu abro a sala, mas assim, a gente só abriu a sala para os speakers e até 200 pessoas, porque senão a gente não consegue monitorar.
Okay.
Okay? Sorry, Venancio, if next time I will...
Alberto, how do you see this case with no intensive care procedures contaminating the causality?
Interesting. I think it's a good point. The post-intensive care cholangiopathy is an entity that has been recognized, and it's something that we need to have in mind. What can we say about this case? I was impressed by the macroscopic picture because that was of a cirrhotic liver, of chronic liver disease. Clearly, this patient had a recent deterioration, and I think putting the two things together was a patient with chronic liver disease, advanced stage, who deteriorated rapidly. Whether we call it a decompensation or an acute on chronic liver failure, I think is debatable. I must say that the histology was not enough, I think, to say that there was a cholangiopathy, to classify the cholangiopathy, and was probably enough to say that there was some acute injury there. But as often the case in these situations, particularly if there is a bit of a gap from the onset of the recent symptoms and transplantation, then you can have all sorts of colonization of tissue by all sorts of cells. And I think also to say that this was an autoimmune hepatitis, I don't know. I think I would like to see more slides and to have a look at the case in more details rather than this, rather than the few snapshots that we have seen. So unfortunately, that's all I can say. I think, again, an acute injury of some sort on top of what appears to be an advanced stage chronic liver disease patient. That's all to say, I think. Again, it would be interesting to hear the comments of the pathologist who reported the case in the first place.
Leila?
Aye.
Now, we have so many cases with cholangiopathy post-COVID, and the patients don't have before liver disease, and then it's a new disease maybe. This is the question.
Quaglia, can you answer this question? She said that's not she could see many cases from after COVID-19 without liver disease. Do you think that's the new partner for the new disease?
It's possible. It has been. I'm aware of cases. I think maybe also Venancio had some direct experience. The question is whether the ACE receptor expression by cholangiocyte is what is triggering the injury. I know that there is a paper circulating for publication. I think we need to see. I think it needs solid data. And maybe we are still in the early. We are relatively, I think, in the early phase of this new disease, and I think we need to wait for data from multiple centers and to make comparisons and then draw some conclusion. But it seems like it's happening because it is a recurrent comment that we hear about the biliary tree involvement in the context of COVID. I haven't seen any case personally, but it seems to be real.
We saw at least 2 cases, and in our Thursday meetings with Venancio and other pathologists, we had a couple cases. And I had the opportunity, probably Venancio saw much more than I, of cases that were submitted to autopsies in the acute phase of the disease. And what is remarkable in these cases is that I couldn't see any change or alteration in the intrahepatic biliary tree. So I think that maybe what happened is consequences of maybe a ischemic cholangiopathy, okay? Maybe ischemic cholangitis. I don't know. I don't know what Venancio think about.
Yeah, in the acute phase, people at our department have been doing a remarkable job on doing minimally invasive approach. I'm not directly related to these procedures, but I've seen the slides, and it's really liver in systemic acute disease and liver in intensive care conditions. So the point is that it seems that some 4 to 8 weeks after recovering, the problem comes, and it would be really important to follow the post-COVID. And the cholangiopathy, we have some cases that we had the biopsy very early and then after some 3 months. And it is so rapidly progressing. Some of the cases, Ilka and Carneiro had performed in Campinas and here in São Paulo transplantation due to these cases, very rapidly progressive. So possibly related to the cytokine storm, some kind of shift of the innate inflammation on immunity towards pattern Th2. And even in the lung, there was DAD, diffuse alveolar damage in the acute phase, very acute, and some not neglectable percentage of cases suddenly go to fibrosing. And the lung fibrosis is terrible, is remarkable. So probably this would be in this continuum. We must have the help of the immunologists, especially those in innate immune response shiftings and commands.
Okay, unfortunately, I have to move on. And Nélia, do you want to briefly comment about COVID in Montevideo, briefly, because I have to move on to Professor Quaglia last talk in this meeting today.
Okay, do you listen to me? Do you listen to me? No?
Yes.
Yes? Okay, yeah. Here in Montevideo, COVID is in progress. We have so many cases, but we don't have any cases about cholangitis or hepatitis yet. And I have some suspicion, but nothing confirmed about that. And I'm not sure about the case. I think it's very hard to be certain of the link about the two situations. In this patient in particularly, she had a very clear autoimmune profile in biochemical and serological results, and I'm not sure about the relation or the link with COVID, but I think it's probably, it's in theory. We have no cases about that yet.
Okay, thank you very much, Nélia. I move on to Professor Alberto Quaglia. He is a consultant at Royal Free London, NHS Foundation Trust, Professor of Hepatology, Pathology from UCL Cancer Institute. He's going to deliver a mini conference with sharing the experience of the pathologist's point of view. Quaglia, today is unfortunately or fortunately is a webinar, not in Fernando de Noronha for the last time that you have been in Pernambuco, but it's a great pleasure to have you here. You have a good time in King's College and now you in Royal Free. Congratulations and take care. Let's see to hear you on your last talk in our meeting today.
Thank you very much, Leila, for inviting me. It's truly an honor, and congratulations for a very well-organized meeting. So what is the pathologist's point of view with Dili? It is a summary, it's not a comprehensive lecture. I want to say also thank you to Professor Massimo Pinzani, who is our senior pathologist here at Royal Free, and we shared some of the slides on this topic. Now, first thing to say, it's a spectrum of injury in terms of the entity of the damage, from asymptomatic situations to acute liver failure. And it can be caused by really anything, from prescribed medication, over-the-counter medication, recreational drug use, natural herbal remedy supplements, and now I think internet prescriptions. It's absolutely scary what people can obtain on internet quite freely. But I think what this tells us is that we really need to think of anything as the possible cause. And when we say anything, it really means that. I remember a case that Venancio probably also remembers. It was circulated by Neil Thies, a pathologist in New York, at one of our ALPS meetings, of a young lady who every time she dyed her hair, she developed liver injury, and she was biopsied, and she had the most amazing hepatitis. I couldn't find the case to share it, but I found a case report from Japan exactly similar. And again, just to say that we really need to think of anything and have really a detailed clinical history when we look at these conditions. And another comment from the point of view of the pathologist, that we rely completely on the clinical history that the clinical team give us. And for us, it's very difficult to obtain more details because we are backstage, so we don't have access directly to the clinical information. So again, the detail of the clinical history for us is absolutely critical. I use this excellent, relatively recent review on the New England the Journal of Medicine as the basis for my talk. And as Professor Hernandez mentioned in her first talk, traditionally we think of hepatotoxicity as direct and idiosyncratic. So the direct is common, dose-related, predictable, and reproducible. The idiosyncratic one is the opposite. And there is, to some extent, good correlations in terms of the phenotypes of liver injury, as we are going to see in a moment, and the causative agents. But now there is an emerging concept of the indirect form of hepatotoxicity, which is somewhere in between. And it basically relates to forms of injury that is due to the agent making worse or exacerbating an underlying condition. So an example is patients with fatty liver disease who receive drugs which make gain weight or alter the sensitivity to insulin, and then the fatty disease gets worse. Or another one is reacerbation of hepatitis B after chemotherapy. So those are examples where, again, sometimes this concept may be a little bit difficult to accept. And again, it's maybe still controversial. But certainly from our point of view of pathologists, when we're asked the question whether, in, for example, a steatotic liver, what we see under the microscope is the result of the underlying disease or may be related to an effect of an additional drug, I think it gets very complicated. And I think for us to draw exactly a line in these situations may be complicated. Now, this is a good table. I think it summarizes well the main histological and clinical phenotypes of acute of drug-induced liver injury, correlates it with the type of injury in terms of direct, idiosyncratic, and indirect, some chronology, the enzyme pattern, the agents, and some additional comments. And I'm going to use it to describe a few examples in a minute. But before doing so, I just want to make a couple of additional points, particularly in terms of the histological counterparts to the clinical phenotype. And as I said in my earlier comments, the way the liver reacts to injury is relatively limited. So we have a set of histological patterns of liver injury. And they're the same for any sort of cause of liver disease. And the Dili phenotypes are essentially identical in terms of histological lesions to other types of liver injury. Hepatotropic and non-hepatotropic viruses, some acquired or inherited metabolic disorders, and autoimmunity. That's why, similarly to the clinical setting, the histological diagnosis of Dili is often a diagnosis of exclusion, and the clinical history is absolutely critical. Particularly in the setting of acute hepatitis, for us, it's really impossible to tell you whether that particular pattern of injury is drug-induced, whether it's caused by a virus, or whether, for example, is the early manifestation of autoimmune liver disease. So that's why we rely entirely on the clinical history. The other important point to make is that sometimes we are asked to comment on the severity of liver injury and the prognosis. And yes, we can see more or less severe injury in a liver biopsy, but we always need to remember a sampling error. And again, this sort of assessment is based on clinical pathological correlation. Now let's go through some cases. Acute hepatic necrosis, the phenotype, usually direct with an abrupt elevation of ALT, often due to overdose. Histologically, usually what we see is this type of injury. This is your reference, your normal reference. For those who are not familiar with liver histology, we have the centrilobular area with the hepatic granule in the middle and the portal tracts at the periphery and the intact hepatic plates. This is a case of acetaminophen-induced liver injury. It's a liver explant. We see the extensive coagulative type necrosis of the hepatocytes with some steatotic remnants and a little cuff of hepatocytes around the portal tracts, clearly not sufficient to compensate for liver function, and this patient had to have a liver transplant, of course. The acute hepatitis is probably the most common, usually attributed to an idiosyncratic type of reaction. In many cases can be fatal. And what do we see histologically? Again, this is the reference point of normal hepatic plates. See the hepatocytes here. And this is an example of a high magnification of an acute hepatitic picture. We see an inflammatory focus here with mononucleate cells around the hepatocytes. There is an apoptotic body. We often see histological cholestasis. So this is a mild lobular hepatitis. In some more severe cases, you see confluent hepatocellular loss, as we see here, a few apoptotic bodies. And in more severe cases, you see that the hepatocytes have been completely wiped out. There is a ductular reaction trying to compensate the hepatic injury, but basically the hepatocytes are extinguished. This patient had a liver transplant for what we thought was a drug-induced acute liver injury where there was barely any liver left. Now I'm showing this picture because this is a case of submassive necrosis. These patients often manifest with subacute liver failure, and there is a tendency to relate this type of damage to drug-induced liver injury. And as you can see, if you take a biopsy from this liver, what the biopsy will show you is exactly what the needle has hit. So it is not really reliable in terms of judging the extent of parenchymal injury, because you may hit a region where the hepatocytes are preserved, and then you are reassuring the clinician. But if the needle is, in contrast, an area of confluent collapse, then you get very worried that there may not be any liver left. And yet, sampling variation is here needs to be considered. We often see granulomas on liver biopsies. Unfortunately, they are very non-specific. They can be associated with absolutely anything. And certainly, from our point of view, we need to do a full workup, first of all, to exclude an infective agent. This is another situation, so-called enzyme elevations, a bit non-specific, considered to be a direct type of injury. And what is interesting is that this type of injury is usually transient and asymptomatic. This is an example. Maybe Venancio recalls this case. Again, I circulated to the Alps a couple of years ago. Was a 67-year-old gentleman who had a form of acute liver injury, was in the end related to a check inhibitors therapy. But the biopsy was taken after the peak of the transaminases. And as you can see, there is barely anything here. The liver looks almost entirely normal. And what you can see is very, very focally a few scavengers, a few macrophages, which are probably just mopping up some of the injury which is left. And unfortunately, that's a situation that we see from time to time, often regularly, is when the biopsy is taken once the episode has finished. We may see sometimes some changes in the hepatocytes which are related to perhaps an adaptation to the drug itself. But it's, again, often hard to make any comments. These may be isolated episodes. They may not come back again. We don't know whether the patients then later on develop others of these episodes. And it's simply difficult to make a call about the specific cause, or whether, in fact, instead of being an isolated hepatitic episode related to a particular drug, it's in fact the early manifestation of a chronic liver disease like autoimmune hepatitis in most cases. Now, in terms of cholestatic injury, again, this is our reference slide in terms of normal liver. Normally, we do not see the biliary canaliculi. We see they're too narrow to be seen at with a normal light microscope. But we do see them when they start accumulating bile. And we see, as we see in this case, they are distended and contain bile plugs. In terms of drug-induced cholestatic injury, we have seen that in the context of acute hepatitis, we often see cholestasis. Histologically, we use the term bland cholestasis when we have those instances where the only histological change is really the accumulation of bile inside the canaliculi without a significant hepatic components or anything in the portal tracts that make us think of a concomitant compromise of the biliary tree. I think the question often in these cases is whether the patients have an underlying genetic condition, and in particular a familiar cholestatic condition, which to some extent we can answer in the pediatric phase, but in the adults, there isn't really much we can do histologically. It needs molecular genetics. In some instances, and we know it's a particular phenomenon that is observed in patients who take antibiotics, the cholestatic picture may be associated with the damage to the interlobular bile ducts. And these patients may develop, sometimes in a short period of time, sometimes in a longer period of time, the so-called vanishing bile duct syndrome. And we are often asked as pathologists to comment if the patient is already ductopenic. We are often asked to count the number of portal tracts. And I can tell you that it's not the easiest thing to do, especially on thin biopsies where the portal tracts are partially represented. We may see some injury to some of the ducts, but sometimes it's simply a single biopsy not enough. We may need serial biopsies. Sometimes we need to cut even multiple levels to make sure that we are not missing a portal tract. So there isn't such a thing as a specific number to use. Again, it depends most of the time on a good clinical pathological correlation and often on following the patient up and see how it progresses. Acute fatty liver and lactic acidosis is, I think in my experience, is rare. The histological pattern is of a fine vacuolation of the hepatocytes. Some of them can show conventional steatosis. I've seen probably a couple of cases in the last 20 years or so. One was a very young patient, and the question was whether she had, in fact, an underlying mitochondrial disorder. But in my experience, it's rare. Non-alcoholic fatty liver, as you see, is mentioned in the phenotypes of drug-induced liver injury. This is an example of a patient with a fatty liver disease on biopsy and a suspicion of a drug-induced injury. Again, it's now used as an example of indirect hepatotoxicity. And from our point of view, as I said at the beginning, I think it's hard to tell the clinician whether the steatosis that we see is simply part of the underlying NAFLD or whether there is some sort of effect related to a drug. One of the examples is often we are asked in patients with psoriasis whether the presence of fibrosis in a steatotic liver biopsy is directly related to the dosage of methotrexate. And it is really hard because often these patients have NAFLD and they may also have alcohol-related liver injury. So how do we answer that question? I don't know. And I think it's many of my colleagues are in agreement with this. The sinusoidal obstruction syndrome, we do see it. These are a couple of cases. Again, this is our reference image of the hepatic plates. You see red blood cells in the sinusoids. And these are congested sinusoids in a case of sinusoidal obstruction syndrome. In fact, this was a resection specimen of a patient with colorectal metastatic liver disease who had chemotherapy before surgery. And there are variations in terms of the severity. This is simply confined to some congestion and some spillover of the hepatocytes in the hepatic plates. This is again our reference point. This is another case with a more dramatic example with quite a lot of hemorrhage in the centrilobular area. And as we mentioned earlier, it's something that we do see more in relation to chemotherapeutic agents, rarely or very rarely in the context of herbal remedies. And again, the point to make here that we are often asked about chronicity and severity of the sinusoidal obstruction syndrome. And on a liver biopsy, we always have to remember sampling variation. Nodular regenerative hyperplasia is another pattern of injury. It's described with thioguanine, azathioprine, and oxaliplatin. Just an example to show you here. This was a patient on azathioprine developed. You see the nodular arrangement of the hepatic plates without surrounding fibrosis, in contrast to what we see usually in a cirrhotic liver. Now, chronic hepatitis is something that comes frequently in terms of relationships with Dili. Again, it is a very challenging aspect histologically to relate chronic hepatitis to Dili. There is an overlap between drug toxicity and autoimmune liver disease. There are some drugs which are particularly known for causing this. Clinically, these patients may have raised immunoglobulin and autoantibodies. And I think, again, here it's a question of clinical pathological correlation. Histologically, they can be absolutely undistinguishable. On a liver biopsy, they can look very much the same. And often it needs a good discussion with the clinicians to decide exactly what to call these lesions and whether to start therapy with steroids. Not mentioned in that review are tumors. We are well aware of the effect of drugs in the development of hepatocellular adenoma, and in particular, androgens and contraceptive steroids. We are well aware of cases of angiosarcoma related to exposure to toxic agents. Now it's very rare. We are aware of some cases of cholangiocarcinomas. Again, we have seen recently an example in a study group. And I think there are, probably there is a question mark exactly on the role of toxicity in the development of hepatocellular carcinoma. We do see many instances of HCC originating in outside the context of cirrhosis in patients who do not seem to have any other form of liver disease, and you wonder whether there is some form of toxicity involved. So my summary, I think those are the main points that I use when I think of drug-induced liver injury. First, that there are many potential sources of drug-induced liver injury, and that we have to expect the unexpected. The hair dye, I think, is a good example. As histopathologists, we need to identify the histological pattern of liver injury. That's the first thing, and I'm completely in agreement with Venancio on that. Then we need to confirm if there is a known association with a specific drug based on the literature available. I use a lot liver tox, as many of my colleagues. We have to remember that histologically, drug-induced liver injury can be absolutely identical to other causes of liver injury. And that's particularly true in the setting of acute hepatitis. Very important to remember. And so it's very important to do the best we can to rule out other causes of liver disease. The question of Dili and a pre-existent liver disease is an interesting one. Sometimes we can answer that. So we can tell you this patient has chronic liver disease and an acute injury that could be drug-induced. So for example, we had recently a case of an alcoholic, cirrhotic, who had taken antibiotics and became suddenly very cholestatic. And I think that was probably what happened in that case. But what is exactly the relationship, particularly in the context of what is now considered to be the indirect hepatotoxicity? I think it's very hard to draw a line between pre-existent, the effect of drug, or even if the underlying condition has lowered the threshold for a drug-induced liver injury. Dili is a clinical pathological diagnosis. I think the clinical history is absolutely essential. And when we are asked to assess the severity of liver injury, we always need to take into consideration sampling variation. And again, it needs clinical pathological correlation. So that's all I have to say. So I thank you very much again. And I put a picture of my native Liguria in Italy.
Thank you very much, Alberto, for your marvelous talk. It's a really clear and wonderful correlation for us hepatologists and pathologists together. I think the time is over, unfortunately. I have to say thank you very much indeed for all my colleagues in Brazil and international friends as well for the last 2 hours online for the Liver Talks webinar for this year. Before you finish, we close this section, I'd like to request two requests. You have to put full screen, Adriano, to take a photo for our final registration for the meeting on the screen. All put the cameras on, please. And also to ask my colleagues from UK to send yours talk to your lectures to our email, because for the end, for the meeting, you'd like to publish in this our site meeting. Okay, in your permission as well. Okay, thank you very much indeed. Venancio, Freitas, Devora, Mateus, Aécio.
Thank you very much.
Gautam, Alberto, and Leila.
Bye-bye, ciao, ciao.
See you next year, I hopefully on presential.
In person, yeah, bye.